let's go.
Good afternoon, good morning. I'm here to introduce Dr. David Millett. He is the director at the Hoag Epilepsy program. He's spent the last 9 years in Southern California. He completed his fellowship in EEG and epilepsy at USC, and he also created the EMU at Rancho Los Amigos, which is in the greater LA area. He received an award from the Care and Cure Fellowship for his work and research, and as I previously stated, he's the director of the Hoag Epilepsy program and has been since 2014. He's going to discuss understanding your EEG today. Welcome, Dr. Millett.
Thank you, Sherry. Thanks everybody for coming. I'll leave the door open. Looks like we're going to have some more visitors, so which is great. This is probably the we didn't do these lectures, I think, during the COVID years, 20 and 21, but I think I gave this talk for the 4 years before. The first time I gave this talk at this event, we had 8 bar stools set up in the corner of the room. We didn't have projectors, and we didn't have computers. Maybe we'll close the door at this point in time because we'll just get the door. So some of you may know me. Some of you do know me in the room, and you probably know I try to keep things informal, and I try to keep them specific to questions or problems that people have. So this is a talk on understanding your EEG. I read a lot of EEG. I read a lot of EEG in different formats. I read a lot of inpatient EEG, a lot of ambulatory EEG, and we have intracranial EEG for patients that are being evaluated for epilepsy surgery, and then we have some newer, sort of rapidly deployed EEG systems that are coming online for hospital use. So we're going to get back to that as well. So. I guess it is a bit of a disclosure. I work very closely with Brad Levy, who's the organizer of this conference. I'm the medical director for EEG2Go, which is his company that does in-home ambulatory video EEG. So I probably read about 600 studies a year for Brad. And probably some of the EEG examples I'll have here are from some of those studies, of course. So I'll start with a bit of history. I used to start all my talks with history, but I've kind of gotten out of the habit. My PhD is actually in the history of brain physiology. So these are some sort of images from not only from the past, but from my past, because I spent some time in libraries sort of reading and understanding about some of these folks. So sort of in the bottom left-hand screen, this image here, and I'm sorry, when I walked by one of the other rooms, I thought we had a big screen. We have a little screen, but hopefully everybody will be able to see. These are some images. This is Hans Berger. This is a German psychiatrist who actually came up with the concept of EEG, or being able to record energy from the brain. He was actually searching for a physical measure of mental telepathy. He had a personal belief that one could send thoughts and feelings across space and time. He had a life-changing event, and he spent 20 years of his career trying to figure out how one could do that and how you could measure energy as it's transformed in the brain. So the EEG was actually his brainchild, if you will, of a lifelong search for mental telepathy. Of course, he didn't necessarily prove that mental telepathy is real, but he did actually discover or invent a very useful neurological and medical tool. That tool really took off in the hands of several research groups in the United States. In particular, one in the Boston area. So this is an image here of William Lennox and Fred and Erna Gibbs. So this was the first group really in the United States to begin to use the EEG looking at different neurological conditions, including epilepsy. And you can probably see the scrolls that they have that they're winding and unwinding. So it's kind of, I think it's fitting in a talk on understanding your EEG to remind ourselves that people, have been studying EEG almost like they studied Talmud right off of scrolls or the Bible for many years. We don't do it this way anymore, but this was when EEG was really just 3 squiggles on a page or 5 squiggles on a page, and you would have scrolls and scrolls, or when they had folding paper. I mean, the big development in the 1950s was they went from scrolls to actually folding paper, and so you could stack it rather than roll it and unroll it. Of course, it's all digital now. So, but these are some very nice images from the past. These are the first 2 sets of epilepsy surgeries that were performed, guided by EEG. So this image is from Herbert Wilder Penfield in Montreal, and this is the Gibbs with a surgery team in Chicago in the 1950s doing the first. This is Herb Jasper with William Penfield, and this is Gibbs and Lennox in the operating room, again in the probably late 1940s, early 1950s, doing the first temporal lobectomies or epilepsy surgeries based on EEG. So we'll move on to sort of the mainstream topic, if I can get, there we go, images to load. So I'm just going to basically go over some basics of recording, how we acquire the EEG today. Of course, all EEG is now digitally acquired, stored, analyzed, and displayed. And what you see on the left is are 2 diagrams of the human head with a bunch of electrode locations on them. So this is the code, or what we refer to as the International 1020 system. There is an international system for electrode placement. So when somebody says FP2 or P6 or whatnot, we know, everybody in the world of EEG and epilepsy and clinical neurophysiology knows exactly where that electrode sits on the head and where those rhythms are coming from that they're moving around. So there's a system in place, and as probably in the front of the room, you might be able to see each one of these little markers over the head has a letter and a number, generally speaking. So F is for frontal, C is for central, T is for temporal, P is for parietal, and O is for occipital. The numbers designate basically the space or the diameter from the midline. So Z is always Z is the midline, and then as you go further off the midline, the numbers increase. So we have, for example, C3, odd is left and even is right. So we have C3 and C4 and F3 and F4, for example. We have P is a subscript for the poles, basically right above the eyes. And then A1 and A2 are the left and the right ears, respectively. Each of these cranial electrodes, scalp electrodes, are essentially 20 degrees apart based on the angle as it's measured from the nasum to the inion, and then the difference between the ear, the corner of the eye, and the ear electrodes are 10% of that distance, which is where we came up with Herb Jasper in 1958 came up with the 1020 system, because 1020 refers to the diameter that those electrodes are spaced. So we've been using this system of recording electrodes for almost 70 years now. And although traditionally the electrodes have been placed basically since the beginning of EEG, with some kind of a paste and metal electrodes affixed to the scalp with paste or collodion, although most places have got away from collodion, and gauze. Many places are now using caps because obviously they're a little bit, as you can imagine, they're a little bit easier to get on and get off. They're quicker. You don't have to measure and affix each one of the electrodes individually with the cap. You basically place the cap on, and then you can squirt some gel inside each of the contacts to make an electrical contact with the scalp. What I've also included at the bottom are sort of two of the newer developments in electroencephalography, or EEG. On the left, we have sort of what we refer to as a rapid deploy EEG, or rapid EEG. This is one of a few brands that is available. This one's called Cerebel. Zeto is another brand. But and NK also makes a system. These are all EEG manufacturers, some of which are going to be in the hall today. These are basically intended for patients that are in an emergency room, in a hospital, in a situation where it's urgent that we obtain real-time, quick EEG for the purposes of figuring out whether they're in status epilepticus, which is a very dangerous, life-threatening condition, or not. So these typically are systems that can be placed without the assistance of an EEG technician. They can be placed by a nurse, by a medical assistant, anyone who basically can read the very simple instructions. This is a headband that goes just around the head. So obviously we're missing a number of electrodes at the top of the head with these kinds of simple systems. But what we sacrifice in coverage over the head, we make up for in the speed at which this can be applied. So we can get real-time EEG in about 7 minutes with the application of this device, which is really useful for hospital systems, emergency rooms, where we need to make some decisions very quickly about how to manage patients. Whereas this will take about 40 minutes from the time that the technologist arrives at the hospital to get an EEG up and running. And sometimes, if they have to call that person in, it might be longer. It might be an hour and a half before the neurologist actually has real data that they can look at. Here in the bottom right corner, this is probably the biggest development in surgical epilepsy care in the last 25 years. Basically, this is the development of what's called stereo EEG, or minimally invasive EEG for seizure mapping from the brain. So this is a patient that has 9 electrodes. These are all thin needles with between 8 and 10 contacts along the bore of the needle for measuring the electrical activity at different depths of the brain in a variety of locations around the temporal along the right. So it used to be that any patient that needed mapping of seizures from the brain, like this patient, would have required a big, what's called a craniotomy, a big scar here, where they would have pulled back the skin and the soft tissues. They would have they cut the bone and created what's called a bone flap, and exposed the underlying brain and placed grids of electrodes directly on the brain, put the bone back, put the skin back, admit them, have them come into the hospital for a week to record seizures. So this gives us an opportunity of essentially recording very similar, and in some ways better, in some ways a little bit more limited information. Everything has its trade-offs, but this can be done in about a quarter of the time in the operating room, and patients the next day are smiling. They can eat, they can talk. I don't know if I know there are some people in this room that have had the procedure already done. It is a much more humane procedure than the old-style craniotomy, which usually had a lot of discomfort associated with it. So this is kind of just a sampling of the scope of EEG that we typically perform today. I'm going to talk a little bit about what we call bandwidths. So EEG is electroencephalography is a recording of the electrical activity of the brain, and that electrical activity typically appears as rhythmic activity. So there are normal background rhythms of the brain in wakefulness and in sleep, and they have different frequencies or cycles per second in different parts of the brain and during different states of awareness or alertness. So sleep and wakefulness look completely different from one another. And somebody who's trained in EEG doesn't need to see the patient, doesn't need to see the camera, all they need to see is basically the brain waves, and they'll be able to tell, is that patient awake, are they drowsy, are they in sleep? If they're in sleep, what part of sleep are they in, what stage of sleep? So the bandwidths here are organized from the fastest activity, which is beta. Beta is essentially the fastest activity that we can record from the scalp. And so this is up to between 30 and 13 hertz. So anything over 13 cycles per second, up to about 30, we can easily record from the scalp, usually when patients are relaxed and still. The problem is that when patients are awake and their muscles are active, their facial muscles, their temporalis muscles, their frontalis muscles, it will tend to create muscle artifact in the EEG. If you've ever had an EEG done and you've looked over at the EEG screen and you see it's black, like the lines are really thick and dark and black, that's not the brain. That's the muscle artifact that is obscuring the underlying brainwave activity. So one of the things that happens with the bone and the soft tissues is it tends to filter those faster activities from the brain. We do have, the brain does make electrical signals that occur faster than this. So they're typically referred to as gamma rhythms in the brain. But all of that signal tends to be filtered out by the skull and the soft tissue. So the fastest activity that we can record from scalp EEG tends to be beta activity. From beta, we drop down to alpha. So the alpha activity characterizes anything that's between 8 and 13 cycles per second, or 8 and 13 hertz. And there are basically two areas that from the brain that we will often see normal alpha activity. So the most common, which almost everybody has, is what's called a posterior dominant rhythm, or PDR. So if you see posterior dominant rhythm or PDR in your EEG reports, that is a normal background rhythm reported from the occipital or the posterior area of the brain. It tends to be within this range of, although it's by definition it has to be between 8 and 13 hertz. Most of the time it's between 9 and 10 hertz. Sometimes we see some folks that have slightly slower alpha, slightly faster alpha, but typically it's between 9 and 10 hertz. And occipitally will sometimes have this beaded appearance where it grows and diminishes and grows and diminishes. So this is a very typical appearance of alpha. Well, I'll go through some examples. This is just for illustrative purposes. The other area of the brain that we often see alpha is over the frontocentral head region. That's called a mu rhythm. Usually patients are relaxed, eyes open or eyes closed, but they can't be moving at that time. It's sort of the motor and premotor cortex of the frontal lobe sort of preparing to move. And so we'll oftentimes see alpha recorded over that part of the brain, completely normal. Theta activity is one sort of bandwidth slower than alpha. So this is the 4 to 8 hertz, or 4 to 8 cycles per second electrical activity of the brain. During development from small children into teenagers, there tends to be an increase in frequency over time. So theta is the typical bandwidth for children under the age of, let's say, 5. the posterior dominant rhythm of a 3-year-old is about 5 to 6 hertz. 4-year-old is about 7 to 8 hertz. So we only really get into the normal alpha, posterior dominant rhythm alpha range of 8 hertz as kids start to develop around the age of 4 to 5. Below that, or younger than that, their background activity tends to be in the theta range. Theta can be normal over the the temporal lobes as older patients are drifting off to sleep. And during light sleep, we often see quite a bit of theta activity. Deeper stages of sleep, we see theta, but we also see theta mixed with what's called delta activity. So the delta tends to be the slowest activity that we record from the scalp. It's between 1/2 hertz and 4 hertz, or up to 4 cycles per second. And this is very typical of the deeper stages of sleep, what we call N3 sleep, or slow wave sleep. We'll see quite a bit of theta. And young children can have, in their background activity, can have sort of a mixture of both theta and delta activity as part of their background. This is just an example of an abnormal rhythm. So these are the spike wave discharges. We'll see some more examples of this, but it's a very clear illustration of what's an abnormal epileptiform rhythm that consists of an initial spike. The spike is the spiky part, less than 70 microseconds or milliseconds in duration, and then it's followed by an aftergoing slow wave. So this is a spike wave complex. And this typically indicates either a seizure if we see it during a clinical change, because seizures, by definition, require a clinical change, a movement change in movement, sensation, cognition. There's a clinical change that's associated with most seizures. And if we see this kind of a pattern accompanying the clinical change, that's a seizure. We can also see in fragments of this that happen during sleep or during wakefulness without any change. Patients don't even know that they're having spikes, don't even know that they're having spike wave complexes, focal sharp waves, or bursts of this activity quite often. Those are interictal epileptiform discharges. The term interictal and ictal, so you'll hear that or read that quite often in your reports. Ictus is Latin for event, so it really just refers to the seizure in most EEG reports. And interictal means between seizures. So interictal is just a very fancy Latin medical way of saying background. Patient's not having a seizure during this time. This is just background activity that we're capturing. Ictal means reported during a seizure. So, just raise your hand if you guys have any questions. Stop me along the way. I don't really want to get to the end and then have people waiting on questions for 30 minutes.
I just thought of something. What kind of way would it show if somebody were meditating?
So it typically it's depending on, I mean, there are different types of meditation, and I'm not an expert in this field, but there's actually a literature on this, and I'm not going to try to wave my hands, but there's sometimes you can see some slowing, sort of a relaxed state, but I think patients that get into deeper stages of meditation can actually have more of an awake and alert type of attention. Yeah.
So you were saying that the spikes have to be present with an outward physical change?
No. When they do, it's usually indicative of a seizure. Okay.
So that would be an epileptic.
That would be an epileptic event. Yeah. And it can be a quick jerk, like a myoclonic jerk. Mm-hmm. It can be a staring spell. We'll see some examples of it. So maybe I'll just go on. And then if you still have questions, please let me know later on. So any of you who have actually looked at your EEG in a report or seen examples of EEG will recognize that an EEG really consists of a series of squiggles across the page. And some Some EEGs are a little bit more difficult to read, and some are easier to read. In my mind, I prefer having all the squiggles be black, although some people do red and blue and red to color code different parts of the brain. I also prefer to have spaces in between the different parts of the brain that we're recording, because when I read EEG, most of the EEG that I read is long-term EEG, so I'll read 24 hours in about 12 or 13 minutes. So it's a very, very fast scanning of EEG, and so having a way of distinguishing the different parts of the brain as we're flying through an EEG is very helpful. So what I'm basically trying to illustrate here is the fact that the EEG is a two-dimensional representation of the electrical activity over the brain, which is a three-dimensional structure. And the only way to do that is basically to take different parts over the head and to connect them up in certain ways that make sense on the page. And the way we do that, that's called a montage. If you heard the term montage, montage just refers to the different ways in which we can display the electrical activity of the brain on a page. So this is called a bipolar montage, and by the term bipolar, I'm not talking about depression and mood disorders. We're talking about the fact that electrically we're calling one of these spots over the brain positive and the other one negative, or subtracting one from the other. We're taking the difference of electrical activity between two parts of the brain, and whatever that difference is, that becomes a signal, and that signal is reflected in a channel. So a channel is a single line of electrical activity across the page. And the way in which we connect those spots, those different electrodes, and then display them on the page is what really gives us this kind of a layout. So this is a bipolar montage, in which each line represents electrical activity at one part of the brain minus the electrical activity, simultaneous activity recorded usually from an adjacent part of the brain. And what that allows us to do is to display in two dimensions the electrical activity over a three-dimensional surface and try to understand it and analyze it visually in a very effective way. This is a standard recording montage that we used when I was training at UCLA, and we still use for a lot of our outpatient studies. And it's organized in a very specific way. So it's typically left side of the brain over right side of the brain. And we are looking here at these four channels. This is the left temporal lobe over the right temporal lobe. This middle group of squiggles starts on the left and comes up over the top of the head to the right. And then these two groups of channels here are also left over right, but instead of starting here and down low and recording the electrical activity over the temporal lobe, they start at the same place, but they come up about 3/4 of the way and record the electrical activity over what we call the parasagittal, or just off the midline. So I'll give you a little bit of a few other examples. There are different ways of hooking up these electrodes to display the information in very specific ways. For example, one of the limitations of this montage, this way of hooking up the contacts on the page, is that it's great when you have a discharge or some abnormality in the middle of one of these lines, let's say the right temporal lobe here. The discharge is right here. It's going to show up right in the middle of one of these sets of channels, and we'll see an example of that on the next page. But if the abnormal electrical activity is here over the back of the head, the occipital area, or over the front of the head in the frontal pole, it ends up being not in the middle of any of these squiggles, of these groups of squiggles, these chains. It ends up being at the end, at the bottom. And so if you can take these, the back of the brain, the occipital or the frontal pole, and put them in the middle of the chain, then you can actually really surround that abnormal activity with electrodes and better understand what it looks like and where it's coming from. So this is what's called a bipolar montage. There's another type of montage called a referential montage. This is a completely different way of displaying the electrical activity of the brain in a two-dimensional format. And what it does is it uses the exact same number, the same electrodes that we use for bipolar, but instead of taking pairs like this and comparing the electrical activity at adjacent spots, it picks one part, one electrode contact or one construct, and I'll tell you what I mean by construct. And it compares the electrical activity at each one of the other electrodes, the other parts of the brain, to that one spot. So oftentimes if we're going to pick one spot, it's the vertex, CZ, the top of the brain. This is called a CZ referential montage. And then the construct, when we use a construct, it becomes an average. Average referential is probably the most useful referential montage that we use. What it does is it takes all of the electrical signal reported from all of the contacts and makes an average, a mean, a mathematical average. And then from that average, it takes the individual electrical activity in each spot and then subtracts it. So this subtracts the average, so FP1 is the left frontal pole minus the average over the entire brain. FP3 or F3 is left frontal minus the average of electrical activity throughout the entire brain. C4 is right central, electrical activity over the right central or right frontal lobe, posterior frontal lobe minus the electrical activity as it's summed and averaged throughout the rest of the brain. So this is a referential montage, this is a bipolar montage, and I'll show you why those two things, it's really important to understand, those two different types of representing the electrical activity. So this is a sort of an animated, it's the same image and the same display of bipolar and referential. But now, instead of just a blank EEG, we have some source of electrical abnormality. It could be a malformation, it could be a brain tumor, it could be a scar, it could be whatever you want. And it's located here over the temporal lobe on the right side, or what would be T4. So this is an irritable lesion that's creating an electrical activity, abnormal electrical activity from the right temporal. And this is these two images show you that this activity in the bipolar type of montage, where we have pairs of electrodes close together, they're really good for locating an abnormality that's very focal. So if you've got a very small, 1, 3, 4 or 5 centimeter abnormality or patch of tissue that's giving off abnormal electrical activities, the bipolar montage is going to tell you exactly where it's coming from, because due to the way in which we display this activity, these spikes are going to point to each other. They're going to locate exactly where the electrical activity is abnormal by pointing to each other. So I don't have the labels on here, but you'll have to take my word for it, that these two spikes are pointing exactly towards each other at T4, which tells us that this is the spot that the right temporal is where that abnormal activity is coming from. This is this exact same EEG, but in a referential montage. So you have to know that T4 is actually located down here. So we see this same discharge displayed in a very different way in a referential montage. Referential montages are great for large abnormalities, sort of things that take up a whole lobe of the brain, a whole hemisphere of the brain. Because what happens is, if this abnormality really extends and takes up a whole lobe or a whole hemisphere, the electrical abnormalities are kind of averaged out. You're subtracting two areas that see the same electrical activity, and it's not as clear in a bipolar as it is in a referential montage. So we use these two ways, these two montages, or ways of displaying the electrical activity of the brain in very different ways. Pardon? Yeah.
Can you do, when you're recording, are you getting both montages at the same time? Or
Yes, so it's digitally, so this was the advent in the mid-90s of moving from paper EEG, because you could only view it in the montage it was recorded to digital EEG, where the individual input from each electrode is stored digitally, and then you can manipulate them however you want. Yeah. And you could also, not only that, but you can adjust what's called the filters. We frequently have to try to exclude very high frequency activity like muscle artifact to see the underlying brain abnormalities. Or there are also slow sources of slow artifact like sweat and eye movements sometimes that we'd like to exclude by filtering those out. So we can digitally manipulate the EEG now in ways that we couldn't more than 25 years ago. Just to give you a sense of kind of how complicated this could be, this is actually not that complicated. This is an example of an intracranial EEG. So these are, remember I showed you that image of the patient that had 8 tiny little, you basically just saw the caps of the electrodes coming out over the scalp. So each one of these groups of channels called on the scalp was referred to as a chain, but we just refer to these as electrode channels now. These all represent the electrical activity along the depth of one of those needle electrodes that goes into the head. One is usually the most distal, so the top, for example, this series of 7 channels. So the top channel here would be the most distal or deepest part of the contact, the part of the brain that's being measured, and then sequentially as it can become closer and closer out to the surface. And I've seen patients that have about 60 or 80 of these channels being recorded and displayed at one time, and we can do up to about 120. It gets very, very messy. This image actually contains a seizure, although, and some of you may be able to pull it out. But right about here, you see the electrical activity in this single channel in the right hippocampus go from this sort of low amplitude background to a little bit of rhythmic activity here that remains quite rhythmic. There's a little bit of a spike associated here, and then it just kind of peters out again. And then the patient pushed the button. They reported an aura of feeling off. And this is the way in which we now are able to map out seizure activity as it's generated from inside the brain in a very, very specific location, because as you can see, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 electrodes. I believe in this patient, 8 were on the right side and 2 were on the left side. And so, although we're covering a large amount of area, we can be pretty confident that her seizures are coming from this one particular location in right middle. This would be sort of the evolution of that seizure. That was just an aura, but at another point in time, you might have a similar event that occurs electrically here, and then although it slows down again, it might pick up as it does here, and then start to spread. And then as it spreads, we tend to see more seizure manifestations. So maybe loss of consciousness, maybe some lip smacking, tongue smacking, responsiveness, gestures with the hands, automatisms and whatnot. And this just basically lets you visualize then the spread of the seizure activity within the brain. So let's get back to Scout, because most people in this room are probably not going to end up trying to interpret intracranial EEG. But call me if you do, because we're always looking for good people. I showed you that image of the one discharge coming from the right temporal lobe. So this is what that looks like in a patient that has fairly frequent discharges. These are now coming from, as you can see, these obvious discharges that interrupt the background. You can tell that this isn't sleep. This is probably N1 or light sleep because the background is mostly theta. The posterior dominant rhythm is slowed to about 7 hertz from the normal background of 9. And these discharges synchronously occur more or less over the temporal lobe and over the central area on the left side. So these are centrotemporal discharges, often seen in children with what we used to call benign Rolandic epilepsy or Rolandic epilepsy. This is now childhood epilepsy with centrotemporal spikes. And this is an image from real-time EEG, this is not croon, of very, very frequent spikes that occur as this child transitions into sleep. So childhood epilepsy with centrotemporal spikes is one of those conditions where we really see an increase in spike wave activity as patients go into sleep. You might see a handful of them, maybe one spike every 10 minutes or one spike every hour while they're awake. But as they transition into sleep, we just see these very, very frequent trains of spikes. There's no clinical correlate to this. So they're sleeping. If you were staring over your child with this EEG, you would not see any physical manifestations of any of this.
I'm sorry.
Yeah.
Quick question. Correct me if I'm wrong. Did Dr. Holder just say that benign Rolandic epilepsy is now called self-limited focal epilepsy?
It is a focal epilepsy, and it is self-limited. There
I
are.
just wrote it down
Yeah.
because as parents, caregivers, we're very confused because sometimes there isn't like a common term.
As experts, we're very confused. That is to say that this is a challenging area of medicine, and the terminology grows up around the technology and around the concepts. And after 10 or 15 or 20 years, it becomes clear that the terminology that people invented 20 years ago and everybody's using now is confusing and doesn't really capture what's relevant in terms of either understanding the epilepsy or picking the right drug or figuring out whether this epilepsy is going to get better or not. So probably the best example of that is petit mal, right? So everybody in this room has probably heard of petit mal seizures. To an epileptologist, petit mal means absence. It's spike wave, 3 hertz, 10 seconds, childhood, right? That is the strict definition of petit mal. To almost everybody else, patients in particular, and older neurologists who trained in the 70s and 80s, petit mal is anything short of a grand mal. So you've got big seizures and you've got little seizures, right? So that terminology is almost useless now because it doesn't even tell us whether it's focal or generalized. It doesn't tell us what drug to pick. It doesn't tell us whether a patient's a surgical candidate if they failed 5 or 7 drugs, right? Or what kind of surgery they need. So the same thing has happened with complex partial. So we used to call, simple partial, complex partial. We've abandoned that and moved to focal and generalized and a more strict description of the seizures. But that particular syndrome of childhood epilepsy with centrotemporal spikes is one of the focal self-limited epilepsies. There are other focal. So Dr. Holder's correct but they're not synonymous, because you can also have a focal self-limited epilepsy from the occipital lobe, and there are rare cases from other parts of the brain as well. Any other questions? 12. Hopefully you guys are getting hungry. So this is basically just a very similar slide that just sort of shows you the advantage of separating out the right and the left sides of the brain, because as I'm scrolling through this, I can see, I can see left spike, left spike, left spike, right spike, right spike, and so you can, it's very easy as you're scrolling through a lot of EEG to get a sense of, is everything coming from one side of the brain? Is there a symmetric appearance of abnormalities from the right and left, or is there like an overwhelming 95% of the abnormal activity is coming from one part of the brain and 5% from the other? This is just sort of another example of just a busier EEG with a lot more abnormality. This starts to get into a condition called Statusepilepticus of slow wave sleep, or electrographic Statusepilepticus of sleep, continuous spike wave of slow wave sleep. This is a condition. This is a that occurs in some children with epilepsy. They may or may not have physical seizures, but they almost always have some kind of regression or loss of milestones, loss of language, loss of motor milestones, anywhere between the ages of usually 3 and 5, 6 or 7. And oftentimes when we hook these patients up for an overnight EEG, you'll see like every second has spike wave activity coming from some part of the brain. Sometimes it's focal, sometimes it's generalized, sometimes it flips back and forth. But this is a treatable form of developmental regression, and so oftentimes when I'm working with Brad and we're screening a lot of kids who are on the spectrum, we're looking for something like this that we can treat with anti-seizure medications and hopefully make them better. This is to give you a sense of what an EEG looks like during a seizure. This is an EEG of a focal onset seizure. Starting here, I know it's hard to see, particularly from the back of the room, but there's an initial spike here, high amplitude over the left frontal, and then you can see these two spikes pointing to each other, like we saw before over the left central. So it's coming somewhere from this area. That's the initial spike wave, and then it just spreads like wildfire. And it disrupts all of the other cerebral electrical activity, and all we see is these very, very high amplitude spike wave discharges throughout the entire brain. So this is a rapidly progressive focal seizure.
What's the time lapse at the beginning of that?
I'm sorry, let me go back. This slide actually, because it's probably so busy, I took out the time markers.
Just curious,
actually, they're still there, but they're completely obscured. This is 1 second, so the entire screen is about 12 seconds. Okay. But this is just an indication of how high amplitude the activity is. If we go back, for example, and I should have said this, thanks for reminding me, but we oftentimes will have time markers on the EEG, and typically every solid line represents 1 second. So, for example, in this 1 second, we'll see 1, 2, 3 discharges coming from 2 different hemispheres. This one we just finished up with. This is a very different type of epilepsy, as you can see, and I've kind of turned down the volume so that you can see it a little bit better. But this is a much more rhythmic pattern. This is also a seizure. This is a generalized seizure. This is an absence, a staring staring type of seizure, and this is of its typical frequency, which is 3 to 3.5 seconds, and the spike waves are typically maximal of the frontal areas. They typically last about 10 seconds, but they can occur anywhere from 8 to 13 seconds. But you can count them out 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is a very typical type of EEG reported from a child who has childhood absence epilepsy. This is just kind of to this is just an image of sort of background slowing. This is typically what we see during transition to sleep, or in patients who have some kind of an underlying abnormality. Oftentimes, if you look very closely, you may find an asymmetry. So, for example, in this EEG, although the left and the right sides of the brain look pretty similar in terms of their slowing, we can look at the PDR and count 1, 2, 3, 4, 5, 6, maybe 6 to 7 hertz of background activity. There's a little bit more slowing over the right side. So you see this kind of big, sharp, slow wave here. You see more these waves that are in the delta range over this time period in the middle of the screen. So there's some, although the EEG in general shows some mild slowing of the background, this patient may be transitioning into sleep, which makes this normal. But if this patient is awake and over the age of, let's say, 5 with this EEG, this background is a little bit slow, and there's a little bit of focal slowing over the right hemisphere in addition to that. So, and then if you look a little bit more closely, if you're sitting close to the room, you might see one of those little phase reversals right here, where those two sharp waves are pointing to each other. So you might, if this is a recurring event, there also may be a focus of irritability here over the left temporal area. So we're basically looking very carefully at asymmetries, at the waveforms, and the bandwidths to try to better understand what state of consciousness patients are in, whether there's a focal abnormality, and whether that is likely the cause of seizure activity. So I think that's kind of the last prepared slide. I oftentimes given this without any slides at all, because people oftentimes come with so many questions about understanding their EEG or the EEG of a loved one. So I'm gonna stop here, and then I'm happy to answer questions.
Can you help us understand the difference between reading EEG of yourself with your eyes versus like computer and AI reading an EEG? I feel like we got an EEG recently where I was expecting to have a conversation with my doctor about the results. The form, though, came back as like nothing really spotted, but it made it seem like it was almost all computer.
We only read the part where you
Yeah. So this is, and I'm gonna advertise my disclosure. I've got to be very transparent about this, right? So I am the medical director of a company that does a lot of this, and we read it and interpret it and store that data in a very rigorous way. And there are other companies that offer similar services, which either will only save bits and pieces of the data, or they will have the data, the primary analyzer of the data be someone who maybe isn't the referring doctor, maybe is or is not an epileptologist. I don't know what their credentials are, but there are companies that outsource the interpretation of EEG. So a lot of it has to do with both the hardware. So Digitrace, for example, I don't know if anybody's had an EEG with Digitrace. These companies have evolved over time, but when I was training, when we got an ambulatory study from Digitrace, it basically saved 10 seconds like every 5 minutes, and then every push-button event. But what you got was a very selected fragment of the whole study. And oftentimes I will still get a request, can you look at my kid's EEG that was done last year or 3 years ago? And it's just, there's, although it's supposed to be a 24-hour study, I've got 40 minutes of data. And that happens, unfortunately, that happens a lot. And it's just, I can't do it justice because I can't really see all the data.
Sure.
So it really depends on kind of the protocol of the company that's doing the study, as well as who's reading it, and how much clinical information, background, and training they have in interpreting the study.
So if we want to be advocates for the kind of data or the kind of reading, we should probably be brushed up on, hey, before I go in for 48 hours, what's your study?
Who's reading the data?
Okay.
And can I get a copy? I mean, it's like an MRI, right? People come into my office all the time for consultation with an MRI report and say, "This, I really appreciate that you brought it, but it doesn't do me any good, really." So because I've seen too many things either overread or underread. So other people that aren't used to reading epilepsy protocol MRIs, and the studies that are all outside of an epilepsy center, they don't even cover the whole head, the whole brain. They won't even sample not necessarily the frontal lobes or the occipital lobes. So what they call epilepsy protocol, what we call epilepsy protocol, are two completely different things. So it's the same in EEG. It really depends on what company's doing it, not so much where it's done, like an MRI, but what company's doing it, what their protocol is for reporting, storing, and then who's doing the interpretation. Yeah.
Does Hoag have access to chalk and UCLA's EEGs?
The reports, but not the data. Nobody really has access to other hospitals' data, but we can, if necessary, we can get it on in digital format. And I've done that before. Yeah.
When you talked about like background frequency,
Yep.
just like in a child with developmental delays, would that frequency be slower?
Usually. But not always. Yeah. Yeah.
My daughter, her seizures are very complex because of her underlying diagnosis of impairment, and then she also has various types of seizures along with having epilepsy. And I want to know what we did, or is it a good idea to have a physician for the EEG and MAG, or is that something that I should need to encourage?
So you mean the EEG and the MEG together? So, they will oftentimes, as part of the MEG, they will get surface EEG oftentimes because they want to see whether the MEG spikes. So let me just take a step back because you're asking a very specific question. So MEG, MEG stands for magnetoencephalography, and it is a complementary technique to EEG. EEG looks at the electrical activity reported over the surface of the head, and MEG, magnetoencephalography, looks at the magnetic dipoles, essentially the magnetic equivalent to a current, an electrical current, as it's also reported over the surface of the head. They are complementary because there are some patients who have electrical abnormalities that are kind of silent to scalp EEG. It depends on the orientation of where this electrical activity is coming from and how deep it is. So those patients that we know they have epilepsy, we know they have seizures, maybe we can see some abnormalities on MRI, but we're not seeing anything on EEG. If we really need to know exactly where things are coming from, because we're thinking of going in with a laser, we're thinking of going in with a scalpel or suction, we're putting an RNS electrode in there to help surgically better manage a patient who can't be adequately managed medically. MEG or MEG oftentimes gives us more precise localization about exactly where seizures are coming from. So and there's only two, as far as aware, maybe somebody in the room can correct me if I'm wrong, I think there's only 2 MEG scanners still in the state of California. There's one at UC San Diego, one at UCSF. There's been a lot of talk about putting one in Orange County or LA County, but there used to be one in Pasadena, but it's not functional. It's an older device, not functional anymore. So there are different techniques to doing it, but they will always want to verify that what they're calling a spike on MEG also can be seen on scalp on EEG and looks abnormal. So.
Because to me, just putting my daughter in that type of surgery, I would want to have more information instead of just subjecting her to that and then it potentially not work.
Correct. Yeah, I need to know the details to advise you specifically. But sort of, I guess as a general rule of thumb, yes, more information is good, but you can also get too much information. And I have had patients who've had a MEG, and the MEG turned out to actually not be quite right. Oftentimes it is, but sometimes it's not. And sometimes it can provide misleading information where you were down a certain pathway and now you're veering off because wait a minute, we've got to address that MEG problem. And at the end of the day, it was just bad information. And we should have just gone on anyway and done what we've been doing for the last 20, 25 years. Right. Other questions? Yeah.
If you have a child in utero stroke, CP, now on medication because seizures started happening, and you're told that even though you're not seeing seizures, that on the EEG there can be shown
Subclinical electrographic seizures.
Yeah. What does that mean?
So it means that some of those yucky patterns that we saw on the EEG are happening even when the child doesn't have any outward physical signs of seizure activity. Beyond that, what to do with that information then becomes pretty complicated pretty quickly, and there's not always a uniform agreement of everybody in the room, even when it's everybody's in the room in terms of how to manage that situation. There are some kids who probably are not reaching their full potential in terms of neurodevelopmental outcomes because of a lot of subclinical or electrical seizure activity. But it requires a lot of attention and detailed information from a neuropsychologist or a developmental psychologist, from the pediatric neurologist, from the radiologist. People have to kind of come to the understanding that, that much seizure activity is probably limiting their neurocognitive development, and we need to do something about that.
So if a neurologist, not an epileptologist, is suggesting that maybe they could come up if they're not seeing seizure activity, come off of meds, after the 2 years or whatever, maybe a reconsideration or a consult with an epileptologist?
You mean we're talking about the same child?
Child, yeah.
Yeah. I don't think that's good advice. In a similar situation, perhaps, or a patient who comes to me who's been seizure-free for 2 years, 5 years, 10 years, and wants to come off of medications, I have to tell them, there are one of two scenarios. We have to be completely open to the possibility of either one, you've outgrown this epilepsy, or number two, you still have epilepsy, but the medication that you're on is doing a great job and has been for years of preventing seizures. The best way we can go about figuring that out is with an EEG, with an MRI, and if those come back abnormal, that definitely places the patient at higher risk for having seizures if we take away the medication.
And so would you maybe try a longer duration EEG to get more info?
You're
Or you
saying if
think
the
it's
short-term
enough?
EEG was
Yeah,
negative?
it's like the standard, oh, no, the short term also showed that look more. So a longer one's just gonna potentially show more.
I would strongly advocate, unless there are serious issues with side effects or whatnot, I would not take the child off of medications.
Follow up on that, would doing a genetic test prior to consideration of
It might give you a lot of other useful information, but it's not going to answer this question in terms of whether to withdraw medications or not.
So I'm on a withdrawal medication path right now, but I haven't started yet. And one of the things I was wondering is if I should do genetic, if they have the gene, is it not a good idea to start to use, depending on the gene?
There, you know,
Complicated, I know.
there are different levels of this gets down to epistemology, or the sort of levels of knowledge, right? So seizure activity is a physical body of knowledge, sort of in space, bodies moving in space and time, right? EEG is an electrical phenomenon reported from the surface of the head or from inside the head. Genetics are at the very basis of cellular and molecular life, and it's not a one-to-one mapping between genes and EEG or seizures and outcomes. It's useful, but it doesn't answer this question. Back of the room, is there a question? I thought I saw a hand go. Yeah.
Hi, is there, when we're looking at our RNS EEG, basically the reading, or what should we look for? Like when we're looking at it, just as parents, and what questions to ask? Because it's new for us as parents, and I know it's just kind of like, do I look at it the same way as looking at a regular EEG or your EEG?
So, you know, we have about 20 patients with RNS in my clinic, and I don't know of any of them that are actually looking at their own RNS data. So do you have access to?
No, when we go to the clinic, I ask to look
see
at
it.
it, yeah, because we
Wow.
want to see.
They're really transparent with everything.
Well,
for
our
therapies.
doctor is, because I'm really interested in seeing,
Yeah.
because right now it's new for her,
Yeah.
and it's at the lowest setting, of course, but just over time, I want to be able to identify, because I ask, it's so new that.
Yeah, can be a steep learning curve. It's a very sophisticated device, and there's a lot of different ways that you can display that data, right? So, you know, there's the seizure detection, there's long events, there's the magnet swipes, there's you can trend things in all kinds of different ways. And then when you get to programming, it can be equally complex. You know, I think that from a parent or a patient standpoint, being able to look at the magnet swipes, that EEG correlate with the magnet swipes is probably the most important thing, and the trends. So what direction are things going in over time? But those would be the things. But if your neurologist is willing to review that with you, and we do that the same, you know, in our clinic, that's great. Yeah.
Is it so? I have two RNSs. By the way, if you have questions afterwards, I'll be willing to talk. But my RNS used to. They would think that the beginning of the seizure is when my RNS did this. It jumped. Recently, they've found that before that it flattens. And so, are most seizures, do most of them start with a big wave like that, or is there a flat point before the seizure starts? Is it just dependent?
Neither. You're unusual.
Okay, I know that's what they've said for years.
I'm not telling you anything you didn't already know. And I have one patient very similar to you.
Okay.
We've never really been able to pinpoint like we can with the scalp EEG.
Okay.
Or even with the intracranial, like that's the start of the seizure. It's right there.
Okay.
And we're seeing it grow and get faster and spikier and spread. And that's can be a very challenging situation to try to program. Your you're flying blind a little bit.
Yeah, yes, we are.
And you know, what you have to understand is that, you know, the RNS really has two different, very different modes of therapy. One is the detect, treat, right? That's the, and so our patients are always hoping, you know, you put it in 2 months ago, why aren't I seizure free yet, right? It doesn't happen that way. And then the detect, treat mode of operation isn't successful right off the bat at the lowest settings. It does take some programming and tweaking it. But the other mode kicks in at about 9 months to a year, that's the neuromodulation. That's because once you're detect, treat, 750 times a day, it's kind of, you're teaching a brain to stop doing that, right? But it takes time for that to develop. And that may be why